Hello everyone. Welcome to this crucial presentation from the Docsaab's diary. Today we delve into a topic of immense importance in clinical practice, benzodiazepine toxicity. Our goal is to provide medical students and doctors with comprehensive understanding of this widespread issue, ensuring patient safety and effective management. Let's begin with an introduction to benzodiazepines. Benzodiazepines are a class of psychoactive drugs widely recognized for their anxiolytic, sedative, hypnotic, anticonvulsant, and muscle relaxant properties. Since their introduction in the 1960s with agents like chlordiazepoxide and diazepam, they have been extensively prescribed due to their superior safety profiles compared to earlier sedative hypnotics such as barbiturates. These medications offer rapid and effective relief for conditions such as anxiety, insomnia, panic disorders, and seizures. However, despite their therapeutic efficacy and widespread use, benzodiazepines are associated with a range of adverse effects, and understanding their toxicity is paramount for medical professionals. The potential for misuse, abuse, and overdose, particularly in combination with other central nervous system depressions, underscores the critical need for comprehensive knowledge regarding their pharmacology, clinical presentation, diagnosis, management, and long term implications. Moving on to epidemiology, a global public health concern, benzodiazepines misuse and overdose represent a significant public health concern globally and regionally, reaching what some describe as epidemic levels. In the United States, approximately 30.6 million adults utilize benzodiazepines, with a notable 5.3 million engaging in misuse, accounting for about 17% of overall benzodiazepine use. These medications are classified as Schedule 4 controlled substances, indicating a significant potential for substance use disorders despite their short term efficacy. Incidents of overdose and emergency department visit related to benzodiazepines have surged, particularly when these drugs are co-ingested with other CNS depressants like opioids and alcohol. A concerning trend noted in 2023 and 2004 in the UK and Ireland involves falsified benzodiazepines, opioids, and synthetic cannabinoids contaminated with highly potent substances like nitagens. These illicit products have led to overdose clusters and numerous fatalities, highlighting an additional layers of risk in benzodiazepine related toxicity. Now let's look at the classification of benzodiazepines. We categorize these medications primarily by their half-life, which greatly influence their clinical use and potential for accumulation. Short-acting benzodiazepines such as midazolam, triazolam, and brotizolam have a half-life of less than 6 to 10 hours. They are typically used for procedural sedation or acute insomnia, providing hypnotic effects without significant daytime hangover. Intermediate acting benzodiazepines including lorazepam, alprazolam, temazepam, and oxazepam have a half-life ranging from 10 to 24 hours. These are often prescribed for anxiety disorders, short-term insomnia, and acute agitation with minimal accumulation in the body. Lastly, long-acting benzodiazepines such as diazepam, chlordiazepoxide, and clonazepam have a prolonged half-life of over 24 to 200 hours, especially with their active metabolites. They are indicated for chronic anxiety, seizures, alcohol withdrawal, and muscle spasm, but carry a higher risk of accumulation, particularly in elderly patients. Understanding the pathophysiology of benzodiazepine toxicity is crucial. Toxicity primarily results from an overdose which can occur through various routes, including oral ingestion, intravenous administration, or co-ingestion with other substances. The core pathophysiological mechanism involves the excessive potential of GABAergic inhibition in the central nervous system. When benzodiazepines are taken in overdose, they bind more extensively to GABA A receptors, leading to an exaggerated increase in chloride ion influx into neurons. This results in widespread neuronal hyperpolarization, significantly reducing the firing rate of neurons throughout the brain. The clinical manifestations are a direct consequence of this global CNS depression and can affect multiple organ systems, although the primary impact is on neurological and respiratory function. Isolated benzodiazepine overdose are rarely fatal, largely because benzodiazepines, unlike barbiturates, have a ceiling effect on GABAergic potentiation. They increase the frequency of chloride channel opening but do not directly open the channel or enhance the duration of opening to the same extent as barbiturates. This characteristics confers a relatively superior safety profile compared to older sedative hypnotics. However, danger arises significantly when benzodiazepines are combined with other centrally acting respiratory depressions such as opioids or alcohol. In such mixed ingestions, the synergistic depressive effects on the respiratory drive can lead to severe hypoventilation, respiratory arrest, and death. Let's move on to the clinical features of acute toxicity. The clinical presentation of acute benzodiazepine overdose typically manifests as symptoms of central nervous system depression. These signs and symptoms can range from mild to severe depending on the dose ingested, the specific benzodiazepine, the patient's individual factors such as age and comorbidities, and crucially, the co-ingestion of other substances. Common clinical features of isolated benzodiazepine toxicity include neurological effects, slurred speech, ataxia or impaired coordination, confusion, extreme drowsiness, disinhibition, and sedation are frequently observed. In more severe cases, patient may progress to stupor or coma. Disturbed consciousness is a hallmark, and in pediatric patients, even a blue-colored tongue has been reported in severe cases. Regarding respiratory effects, while pure benzodiazepine overdoses rarely cause severe respiratory depression, shallow or slow breathing known as hypoventilation can occur. Life-threatening respiratory depression and the need for assisted ventilation are uncommon with oral benzodiazepine exposures alone and should prompt investigation for co-ingestion of other toxic substances. Finally, cardiovascular effects. Significant hemodynamic instability is rare with isolated benzodiazepine overdose. Blood pressure and heart rate are usually stable, although mild hypotension may be observed. It is critical to differentiate isolated benzodiazepine toxicity from mixed ingestion, as the latter significantly increases morbidity and mortality. When benzodiazepines are combined with other central nervous system depressions such as opioids, alcohol, or other sedatives, respiratory depression is markedly more severe and life-threatening, often leading to respiratory arrest. Profound coma and significant hemodynamic instability are much more likely to occur. The overall clinical picture is one of deeper and more refractory CNS depression. The absence of severe hypoventilation or hemodynamic instability in a benzodiazepine overdose suggests the absence of co-ingestions. In pediatric patients, clinical manifestation can range from mild sedation to life-threatening respiratory depression and coma, necessitating timely diagnosis and intervention. Ataxia is frequently the most common clinical finding in children hospitalized for benzodiazepine overdose. Now let's discuss the diagnosis of benzodiazepine toxicity. The diagnosis relies on a combination of patient history, physical examination, and selective laboratory testing. Given the varying clinical presentation and the critical need to rule out other life-threatening conditions, a thorough diagnostic approach is essential. Our diagnostic approaches include patient history. A detailed history is crucial, inquiring about the type, amount, and timing of ingestion, intentionally whether accidental, intentional self-harm, or recreational misuse, and importantly, co-ingestion of other substances, especially alcohol, opioids, or other sedatives. Information from family, friends, and or emergency medical services can be invaluable. Physical examination. The physical examination will typically reveal signs of central nervous system depression as described in the clinical presentation section. Key findings include altered mental status ranging from drowsiness to coma, slurred speech, ataxia, and potentially mild respiratory depression or hypoventilation. Pupils are typically mid-size and reactive, which can help differentiate from opioid overdose, where we see pinpoint pupils, or anticholinergic toxicity, which present with dilated pupils. And for laboratory testing, toxicology screens, urine toxicology screens are commonly used to detect the presence of benzodiazepines and other illicit or prescription drugs. It's important to note that these screens typically detect the parent drug or its metabolites and do not quantify the amount, nor do they perfectly correlate with the clinical severity of toxicity. Some newer benzodiazepines may not be detected by standard immunoassay screens. Blood test Blood test can confirm the presence of benzodiazepines and in some cases quantify levels. However, quantitative levels often do not guide acute management as closely as the clinical picture, except in specific research or forensic context. Blood tests are also vital for assessing organ function and ruling out other conditions. Blood gas analysis. Arterial or venous blood gas analysis can assess for respiratory acidosis, which would indicate significant hypoventilation. Other lab tests, electrolytes, glucose, renal function test, and liver function test may be performed to assess overall physiological status and identify complications. An ECG should be considered to rule out cardiotoxicity from co-ingestions. It's vital to consider the differential diagnosis to rule out other conditions that can mimic benzodiazepine toxicity. Key differential diagnoses include other sedative hypnotic overdoses, overdoses of barbiturates, jet drugs like zolpidem or alcohol can present very similarly to benzodiazepine toxicity, causing CNS and respiratory depression. Opioid overdose. While opioids typically cause pinpoint pupils, severe respiratory depression and profound CNS depression can overlap with mixed benzodiazepine overdose. Naloxone administration can help differentiate and treat opioid overdose. Metabolic encephalopathy, conditions such as hypoglycemia, diabetic ketoacidosis, uremia, hepatic encephalopathy, or severe electrolyte disturbances can cause altered mental status and CNS depression. Neurological events, stroke, whether ischemic or hemorrhagic, seizures in a post-ictal state, or other intracranial pathologies can present with altered consciousness, focal neurological deficit, and respiratory changes. Hypoxia or hypercapnia, severe respiratory compromise from any cause can lead to altered mental status. And finally, hypothermia, hyperthermia, extreme body temperature can significantly affect neurological function. Also, toxic alcohol poisoning such as methanol or ethylene glycol can cause CNS depression and metabolic acidosis. Now, let's discuss the management of acute benzodiazepine toxicity. The management primarily revolves around supportive care with specific intervention tailored to the severity of symptoms and the presence of co-ingestions. The initial approach prioritizes stabilization of the patient's airway, breathing, and circulation. For emergency management principles, airway protection for patient with significant CNS depression or depressed gag reflex, airway protection is paramount. This may involve positioning the patient in the recovery position, inserting an oropharyngeal or nasopharyngeal airway, or in severe cases, endotracheal intubation. Respiratory support, assess the patient's respiratory drive and oxygenation, administer supplemental oxygen as needed. If hypoventilation is present, provide ventilatory assistance ranging from bag wall mask ventilation to mechanical ventilation, especially in cases of co-ingestion with other respiratory depressions. Circulatory management, monitor vital signs closely, including heart rate, blood pressure, and oxygen saturation. Intravenous fluids may be administered for hypotension, though significant hemodynamic instability is rare in isolated benzodiazepine overdose. Regarding gastric decontamination, activated charcoal, the role of activated charcoal is controversial and generally not recommended for isolated benzodiazepine injections unless there has been massive recent ingestion within 1 hour of a sustained release formulation. Its routine use is discouraged due to the risk of aspiration, particularly in patients with altered mental status. Gastric lavage, whole bowel irrigation, these procedures are rarely indicated due to limited efficacy and significant risk. Let's talk about Flumazenil. Flumazenil is a competitive benzodiazepine receptor antagonist that can rapidly reverse the sedative effects of benzodiazepines. However, its use in acute toxicity is carefully considered due to potential risk. Indications. Flumazenil is indicated for the reversal of benzodiazepine sedation used in diagnostic or therapeutic procedures or for the management and diagnosis of pure benzodiazepine overdose causing significant central nervous system or respiratory depression provided specific criteria are met. Contraindications. These are crucial. Flumazenil can precipitate acute benzodiazepine withdrawal seizures in patients with chronic benzodiazepine use or dependence. It is also contraindicated if there is suspicion or confirmed co-ingestion of proconvulsant drugs such as tricyclic antidepressants, cocaine, or bupropion, as flumazenil can lower the seizure threshold. It should not be used in patients with increased intracranial pressure as rapid awakening can worsen this or in cases of known hypersensitivity to flumazenil. Dosage and administration. Flumazenil is administered intravenously. For adults, the initial dose is typically 0.2 mg over 15 seconds. If the desired level of consciousness is not obtained, further doses of 0.3 mg and then 0.5 mg up to a cumulative dose of 3 mg can be given at 1 minute intervals. For pediatric patients, for reversal of procedural sedation, the initial dose is 0.01 mg per kg with a maximum of 0.2 mg over 15 seconds, repeatable up to 4 times to a cumulative maximum of 1 mg. For overdose causing significant CNS or respiratory depression, it's 0.01 mg per kg, max 0.2 mg over 15 seconds, then 0.005 to 0.01 mg per kg, max 0.2 mg at 1 minute intervals, up to a cumulative maximum of 1 mg or 0.05 mg per kg. Monitoring. Patient receiving Flumazenil requires continuous cardiac and respiratory monitoring as resedation can occur due to the shorter half-life of Flumazenil compared to many benzodiazepines. Seizure risk also necessitate close observation. While isolated benzodiazepine overdoses are rarely fatal, as we discussed, complications can arise particularly in severe cases or with co-ingestions. These include aspiration pneumonia, profound CNS depression can lead to impaired airway reflexes, increasing the risk of aspiration of gastric contents, which can result in aspiration pneumonitis or pneumonia. Rhabdomyolysis, prolonged immobility due to severe sedation can cause muscle compression and breakdown, leading to rhabdomyolysis, which can subsequently cause acute kidney injury. Hypoxia and respiratory failure, especially in mixed ingestion, severe respiratory depression can lead to hypoxia, hypercapnia, and ultimately respiratory failure requiring mechanical ventilation. Persistent neurological deficits, while rare, prolonged and severe hypoxia due to respiratory compromise can result in anoxic brain injury and long-term neurological impairments. And finally, trauma. Patients with benzodiazepine toxicity are at increased risk of falls and other traumatic injuries due to impaired coordination and altered mental status. Let's conclude with prevention and public health aspects which are crucial for addressing this epidemic. This includes responsible prescribing practices. This means judicious indication, prescribing benzodiazepines only for clear evidence-based indication and when non-pharmacological treatments have failed or are insufficient. We must emphasize short-term use, typically 2 to 4 weeks for conditions like acute anxiety or insomnia to minimize the risk of dependence and tolerance development. Always start with lowest effective dose and titrate cautiously. Regular reassessment of the need for continued benzodiazepine therapy is essential, and if long-term use is unavoidable, regular reviews are necessary to monitor for adverse effects, dependence, and the potential for dose reduction or discontinuation. Critically, avoid co-prescribing with opioids as this significantly increases the risk of respiratory depression and overdose death. Clinicians should exercise extreme caution or avoid this combination altogether. Lastly, utilize prescription drug monitoring programs to review patients' prescription histories, identify potential doctor shopping, and prevent duplicate prescribing. Patient education. Clearly communicate the risk such as dependence, withdrawal, cognitive side effects, and dangerous interaction with alcohol or other drugs, along with benefits of benzodiazepine therapy. Instruct patient to take medication exactly as prescribed and not to increase the dose without consulting their physician. Warn patients about the dangerous synergistic effects of combining benzodiazepines with alcohol or other central nervous system depressions. Advice on safe storage to prevent accidental ingestion by children or misuse by others, and proper disposal of unused medication. Educate patients about the potential withdrawal symptoms and the importance of gradual tapering under medical supervision if discontinuing the drug. Harm reduction initiatives. This involves public awareness campaigns to raise awareness about the risk of benzodiazepine misuse, particularly when combined with other substances. Given the high rate of co-ingestion with opioids, increasing access to naloxone for patients prescribed both opioids and benzodiazepine can be life-saving intervention. Improve access to evidence-based treatment for substance use disorders, including medication-assisted treatment for opioid use disorder and psychotherapy for benzodiazepine dependence. And finally, public health agencies and law enforcement should monitor for the presence of falsified benzodiazepines and other illicit drugs contaminated with potent substances like Neetpg SN in the UK and Ireland. Rapid alerts and public warnings about such contaminated supplies are crucial. Thank you for your attention and engagement during this presentation, guys. We hope this comprehensive overview of benzodiazepine toxicity has been informative and will aid you in your clinical practice. For more insights and educational content, please like, share, and subscribe to the Docsaab's Diary. We encourage you to reach out with any questions or for further discussion. Thank you.